series. Today's subject is managing stress and burnout during COVID-19 pandemic. And our speaker today will be Dr. Jeff Katzman. Before we get started, we want to remind the network that we have Spanish and French interpretation services available so that you can follow this conversation through an interpreter if you wish. Additionally, the Q&A, for the question and answer session, you'll be able to submit questions in Spanish or French, and the interpreters will submit your question to the speaker for him in English. The interpretation function is the globe icon is on the Zoom control panel down at the bottom of your screen. Please click on Spanish or French. You will then have the option to hear only the interpreter or keep the English softly in the background. We had over 1,700 registrants for today's sessions and are grateful for the time you've taken out of your busy schedule to be with us today. My name is Sanjeev Arora, and I'm the founder of Project Echo and serve as the director of the Echo Institute. On the call today is my colleague and co-facilitator, Dr. Thornton, and an associate director of Echo, who's worked with me on the Echo project for more than a decade. We'd like to thank Dr. Katzman for sharing his time and expertise with us today. Before we begin, we have some housekeeping items to address. Today's session will be recorded, and the video links and the presentation slides from each of the global conversations can be accessed on our webpage. Please note that it may take up to 48 hours for our video team to upload the recording and slides from today's session. Please also note that all participants will be in the listen-only mode for this session. If you'd like to submit a question, please use the Q&A icon down at the bottom. Please refrain from responding to questions in the Q&A. We have received over 250 questions through the registration, and we apologize in advance that we cannot get through all of them. Our digital librarian will be posting the resource links from today's sessions. These resources will also be available online for you to access and share with colleagues and patients. At the end of today's session, we'll post the link for obtaining your CME or continuing education credits. Your feedback is important to us, and we appreciate all of you completing the session evaluation. I'm now going to introduce our speaker. Dr. Jeff Katzman is a professor of psychiatry at the University of New Mexico, where he's currently a vice chair of adult clinical services, education, and academic affairs. He's also the medical director of an international program on psychological resilience training for first responders through Project Echo. He's a longtime student and teacher of the psychodynamic psychotherapy and attachment, and has received numerous teaching awards from trainees. He has been published extensively in these areas for unique thought paradigms. He's currently the director of the Strategic Task Force for the American Academy of Dynamic Psychiatry and Psychoanalysis. And he has presented these ideas at multiple international conferences and has written 2 very well-received books, with a 3rd book coming out in July. I'd like to go ahead now and proceed with the program. Over to you, Dr. Katzman.
Dr. Arora, thank you so much. As you know, I am a big fan of Project Echo and have watched it provide education and change lives. And I just want to thank you up front for inviting me to speak and for everything you've done in creating such a remarkable program that's so important right now with everything that we are all dealing with and have been dealing with this past year. So I'm going to be talking about resilience and self-care, and we thought we'd do this in a couple of parts. So I'll talk first about some general concepts about what tends to happen to people, to us who are involved in helping others and working and in facing the pandemic and in multiple venues. And I'm aware we're all over the world in different cultures and different scenarios, and we all have our unique challenges, some urban, some rural. And so hopefully the words that I say today will ring true for all of you in some way. That after that 15 minutes, then we'll take some questions and talk, and that will help us, I think, prime for a longer section, about 25 minutes on interventions and what to do, which is the bulk of what I want to help people think through and think about what might be helpful in all of our unique situations. All right, next slide. I don't have any conflicts of interest here. And I always like to think about Viktor Frankl. Viktor Frankl was a psychoanalyst in Germany in the concentration camp, asking the question in Man's Search for Meaning that he published, what keeps people going and why don't people run into the electric fence around the camp? And in his most recent book called Say Yes to Life, that came out beginning of this year, these unpublished lectures, he said, everything can be taken from a man but one thing, the last of the human freedoms, to choose one's attitude in any given set of circumstances, to choose one's own way. That's what we want to talk about a little bit. Despite the fact that none of us expected to be alive during such a pandemic, what can we do about it? And how can we feel that we're bringing ourselves to extraordinarily difficult situations? Next slide. Some of us are suffering because we are directly involved in helping people with COVID-19, working in hospitals on the front lines, first responders, working in emergency settings and ICUs, or we're managing people who are doing that and watching the toll that this is taking. And in this scenario, people who are directly involved with helping other people, we see, and this will be not too new to most of you, but I want to get it just down before we talk about what we can do about things. But we see at this point, after many, many months, exhaustion. We had expected curves to be falling, and now they're rising again, and none of us expected this to be going on for so long. We see people with what we call an acute stress response, and we'll talk about what that is, with sadness and grief, and in particular, grief with not enough time to process and not enough time to work through. So we are sad, we are overwhelmed with grief, and then disrupted by the next task to do. We experience worry of all kinds. What's going to happen to people in our family? What's going to happen to our patients? Can I come home to be with my family, given that I've been working in the hospital all day? What will happen if this? And most of us have gone through periods of worry. We also are often isolated, even those of us who are working on the front line with this, often are doing it alone in a rural community. And on our first responder call, I hear about people in rural communities who feel that this really do have an experience, that this is all on their shoulder. And in various ways, we experience anger. We experience difficult feelings sometimes toward people we work with, toward organizations we work in. Why isn't it this way? We need more PPE or whatever the issue might be, but difficult dilemmas in our mind that the situation has brought up. The next slide. Classically from the DSM, the kinds of things that we see as a result of this now are really the biggest is an adjustment disorder. An adjustment disorder is when something bad happens to something and somebody, and they have difficult feelings as a result of it within 3 months following. It's not a benign diagnosis, although it's generally considered the most benign of psychiatric diagnoses because it goes away, but it has a much higher suicide rate than major depression or the anxiety disorder. So it's something to think about. When something happens to us that's new and we have a lot of feelings about it, we're at risk for doing something that is not within our norm. People have, as I said, acute stress reactions, and if it goes longer, post-traumatic stress disorders. People suffer from depression, from the anxiety disorders. We have seen a rise in substance use disorders around the US and around the world. as a result of the pandemic. People are at risk for what's called a brief reactive psychosis. We know that people who are in their family genetically primed for something like schizophrenia or a psychotic disorder, those are often brought on by stress. So we see actually a greater risk factor for people who might otherwise, that those promoter genes may not have been coded for schizophrenia. And we see all kinds of family issues right now that I'll talk about, but these family issues are what are really most difficult for a lot of us. Next slide. We hear these words. I want to define them a little bit. These are not frank, like what we'd call DSM diagnoses or that fall to frank psychiatric diagnostic codes, but we use them a lot. And so here's what a lot of us are dealing with. We have compassion fatigue, and that means that when my mind is so immersed in the subjectivity or the experience of so many other people, that I'm being empathic to so many people, I can lose myself and lose time for myself. And I am exhausted as a result of being immersed in so much compassion without particularly taking time for myself. Burnout is something a little bit different. And we've been talking about burnout among physicians and healthcare providers for a long time prior to the pandemic. And burnout tends to be when we are no longer finding meaning in what we're doing, and we lose a sense of connection or enthusiasm or fulfillment from what we're doing. And that also we see right now. We've heard of COVID fatigue. Many call it caution fatigue. People have become wary of all of the precautions that we're required to take, and some people just don't do it anymore. But we're exhausted by having to live in this new kind of life. And as I mentioned before, many of us have had difficult situations, and we need to grieve those. We need to experience our grief and our sadness and our real feelings that accompany these. But often when we're providing healthcare, there's just not time as we go from patient to patient to patient. Right, next slide. When we talk about an acute stress response or post-traumatic stress disorder, just to put it out there, the things that we think about are that people begin to revisit a traumatic event over and over again, either through nightmares or flashbacks, but there's a re-experience phenomenon, and people are irritable, they become on edge, wondering when the next bad thing is going to happen, and have difficulty sleeping, and they tend to avoid reminders and shut down their emotional experience, and can turn to potentially harmful with like cope. And that doesn't mean that if you have any of these things that you have post-traumatic stress disorder. And we throw the word around PTSD like it's like water sometimes because we're all living in stressful situations. But most of us don't have PTSD as a result of this. Most of us have an acute stress reaction that will really over time, not much time generally, or an adjustment disorder. But most of us won't continue to experience these symptoms for years. Next slide. There's another group of us who are not working directly with the pandemic. We're not taking care of patients directly, but are stressed in a different way. And we are at home, and we suddenly find ourselves in virtual meetings all day long. And that has its own experience of difficulties. We feel sometimes guilty that we're not doing more on the front line, and we can feel detached and isolated and start to feel that we don't have meaning because we don't have the same degree of connection with people that we once had. We can begin to feel lonely and lack a sense of spontaneity as we have many people online right now, but none of us can interact as we might normally, even in our work meetings. And a lot of us have fear of what's going to happen, and so hunker down at home even more. Next slide. There's a term called alexithymia that I like to think about. It's really a description of numbness, of not feeling. And these people have difficulty feeling things inside themselves and in other people. They generally are looking external to themselves and not within themselves for what their experience is. And next slide. And 20% of people in psychiatric clinics feel this, and it's about 10% in the general population of the US have this experience of really not feeling much. It's a risk factor for the development of other psychiatric disorders. Next slide. It turns out that a similar phenomenon is happening now as a result of COVID-19 that we'll call detachment. And a few studies are emerging now, one in Italy, showing that detachment is during this period was a major risk factor for the development of further mental health issues. There was a study of Pakistani medical students who described feeling emotionally detached and disheartened, and one of families in Albania whose rates of depression were quite high, correlating with feeling detached. Next slide. The social psychology literature has long told us about our need to belong, and isolation and loneliness are not good for us. Vivek Murthy, who our prior Surgeon General and now on the COVID-19 task force, wrote a book recently called Together, who shows us that actually loneliness is an epidemic, and it's associated with heart disease, diabetes, worsening dementia, and parallels smoking about 15 cigarettes a day. Next slide. Of course, it's potentially helpful to take periods on our own of isolation. It can lead to creativity, but if left unchecked, if we feel isolated and we experience being alone that way, there's a signal that's activated, our sympathetic nervous system, and if chronic, that, as I said, can lead to these healthcare issues as well as an excessive focus on ourselves, and it makes it more difficult to reach out to others as we think that something's wrong with us and can lead to withdrawal and depression. Next slide. Dr. Murthy also talked about something that's very helpful to think about when we're thinking about our relationships while we're in virtual meetings or living virtually. And that is that we have different circles of connection. We have about a small circle of people that are our inner circle, our close friends. Many of us continue those activities. Sometimes we're living with those people. Although we can have problems with that inner circle as well, as we can't connect with those who are potentially our parents who are or grandparents who are in isolation. The middle circle is people we used to see in the hallways, around work, people we used to go to lunch with, our close friends that we relied on that we can't anymore. And it's difficult to know how to get that back. And then our outer circle, many of us went to conferences, we'd see hundreds of people we'd see maybe once a year. We don't have that either, but these are 3 different ways that we would connect. Next slide. Many of us are suffering issues of what is the meaning of my life. I see patients, many of them, whose life is completely altered because they were potentially in the theater and they can't work anymore. And they're home all day long, or they've lost their job, and the stresses at job, particularly for healthcare workers who feel concerned about coming home and often are taking care of young kids at the same time that they're trying to have careers, and the assault on families trying to take on these multiple challenges has led to people having to quit their job and really a crisis of meaning for many people. Next slide. And many of us work with trainees, and it's good to remember the stresses that trainees have. They generally are under more financial pressure, which can accelerate if, for example, somebody has lost a job. Sometimes they are directly involved with the pandemic, but sometimes they're at home, like a medical student trying to become a doctor online. And they're balancing life roles with kids at home and don't have great ways to understand what residency programs really are, and do they want to be doing internal medicine? What do they want to do? Sometimes they're asked to do things that are really out of their job, out of their expertise, and mostly they lack connection with themselves. medical education is usually based on a cohort system, and they don't have that support, and many find themselves in cities all alone, and also face the stigma sometimes of being a healthcare provider, and what that can mean to others who think that they're at risk for spreading infection. I think next slide. Why don't we stop there?
Well, thank you, Jeff. First and foremost, I just want to mention that we've been running this global conversation series for many months, and it's really it's the first time that we have received a full 250 questions, which are reflecting the extraordinary pain and suffering that our healthcare providers, healthcare workers, which is the predominant audience for this global conversation series, are experiencing. And just reading those questions, two really themes emerged. One is the personal stress people are feeling, but the extraordinary concern that our listeners and today and our participants in this series are experiencing in terms of how should they care for others? How should they, for example, we have like 50 questions related to that from different people: how to boost staff morale, how to deal with staff shortages, and how to support their staff and frontline workers. So not about themselves, but how can they help their colleagues in this situation? Could you briefly talk about that?
Yes.
I know you're going to address many of these things later. Go ahead.
Yeah, thanks, Dr. Rohr. I do think that those are critical questions about how do we help each other during this experience. And the two things I want to say about that is, if you're a manager of any kind, if people are working for you, it's just really important to be available and be visible and have regular check-ins and mutual conversations, if at all possible, that go back and forth, where you're not only providing information, but actually eliciting information and understanding the experience that people are going through. The way often that happens, people are providing care, but being managed over some kind of group meetings and virtual meetings. And so it's more difficult to kind of be there. But if we can, that's really important. I want to give a shout out to a program I'll talk about later at the University of Minnesota that's based on a military model called the Battle Buddy system. And the Battle Buddy system, people are assigned a buddy, but we've taken it a little bit to try to do this in a more voluntary way. But you check in with the buddy at the beginning of the day and the end of the day to try to get a sense of what's how they're doing, what would be helpful. And people in general tend to trust people they work with. That's what's come out in the literature. That's what we see ourselves, is that people don't want someone like me coming into their group necessarily and debriefing. People trust their own units. And so they want to have a process where they can talk to each other about what's going on, debrief with each other. And that's really where the trust already lies. So the more that we can do that, have some kind of process within groups is really helpful.
Thank you, Jeff. So one other question that is coming up is this issue of, is from Mary Garrett. How can the United States prioritize mental health care for the healthcare workers at a system level? And other themes in this area are, what can an administrator do in his hospital, in his clinic, to really make sure that all the workers have this kind of support or recognition, etc.? Go ahead.
Yeah. So the first part of that question, and I will address these a little bit as well in the second part of this talk. We are pretty good at being, quote, mental health providers in this scenario. There's something called psychological first aid, and it turns out that therapists tend to be worse at it. than actual peers and volunteers. And psychological first aid is, how do you check in with somebody who's just experienced a traumatic event? How do you help them? And how do you orient toward what would be the most helpful way to reach out to them? And that's an online training that is fairly brief that people can go through. So some systems have used psychological first aid training and the online modules, and I have a link to that in the second part of my talk, to develop large-scale peer support networks. That's happened at Arizona State. That's happened at the, really impressive way at the University of Indiana, where people have developed immediately these peer support networks that become referral bases for anybody who needs to talk. We at UNM opened up our department to be available for anybody in the institution who wants to talk to us. So we have just free consultation for any of our providers who can just call a line that we've posted, and they can reach out to us. And like I said, some people, it is that they're exhausted or have feelings from providing care. But for many people, it is administrators who are disengaged and feeling like they're not important anymore. So there's multiple levels of this and people that we need to think about. I think as an administrator of an organization, it's good to be able to have meetings in smaller groups where people can talk without raising their hand, and more spontaneously, to be able to talk about what's going on for them, so that you can develop a general temperature of how the organization is doing. I think putting a few people in charge of such an activity in a department is a really good thing to do, to have some people thinking about this and trying different models that I'll talk about. I don't think there's necessarily a right thing to do, but I think that there are many things to think about, particularly this idea that teams can help themselves the best. And so it's a good idea to have at least someone on a team trained in psychological first aid to know how to do that and potentially be the go-to person for a team, say in the emergency room or on ICU teams or in an outpatient clinic in a rural environment, or whatever the scenario may be.
Thank you, Jeff. Over to you, Dr. Thornton.
Thank you very much. Thank you, Dr. Katzman, for this excellent information. There are a couple of questions that came in through the chat. I wanted to ask you, there's a question about can you explain the emerging family issues and promoter genes and situational psychosis again to help understand very unusual behaviors at this time and how to mitigate?
Yeah, we don't know so much about this. We do know that people who have somebody with a psychotic disorder in their family are at greater risk for developing a psychotic disorder themselves. And so certain things are protective, and stress is not one of them. Stress is not good for anyone. It turns out actually marijuana is not good for it either. That turns on the promoter gene potentially, and puts people at risk if that's in their family. So there are various things that can put people at risk for the development of schizophrenia or a psychotic disorder. So, things that are protective are a calm environment in the family and contact and attunement within the family, and not lots of what they would call high expressed emotion.
Great, thank you. And there's a question from Karen Buck. Are you more likely to acquire alexithymia by, quote, powering through and ignoring emotions to do your job, or is it a psychiatric diagnosis that you have or do not have?
Yeah, so I could give hours of talk about alexithymia. Actually, I just gave a talk on The Walking Dead and zombies and why we like them, because it's a little bit of the zombie inside of us. And in part, it is really a phenomenon, I believe, that happens in early childhood. There's an investigator, Ed Tronick, the University of Massachusetts, and he developed a paradigm that's been used for decades called the still face experiment, in which a mother and a child gaze at each other, an infant, and then the mother stops responding and has a still face. And you see the immediate reaction of a child. I mean, and if that were to continue, when we see the relief when she starts to smile and interact again. But if a parent were to continue to be not responsive, a child would have no option but to learn to push feelings down and to not express or even experience them. And that, I think, is what's happening to many of us now. Now we're kind of so overwhelmed and so detached. We relate to that experience. We relate to the experience of not feeling, even just by spending all day interacting without contact, without spontaneity, without play, without interaction, without creative moments in a hallway we start to feel shut down. It also can happen, this kind of numbness, by going from bed to bed, helping people and not having time to experience things. And all we can do is detach. And this psychic numbing is a component of a traumatic response. So it can come from multiple places.
Thank you.
Thank you. Jeff, there's this issue of fear, that healthcare workers are experiencing a lot of fear. It's coming from different places. It's coming from the fact that many of them have had loved ones who have got infected. Some have passed away. They've had colleagues, so many healthcare workers have passed away in this line of duty here. But they're really afraid, of course, to get it themselves, but they're also afraid that if they get it, then they're going to go home and take it to their loved ones. But they have to come to work. That's their ethical duty. And what is your recommendation of reconciling all of this, complex thought process that's going on in their minds, even if they're not lonely? They have responsibility, they have their profession, they have their livelihood. And this applies to all frontline workers, not just healthcare professionals.
Absolutely, yeah. Absolutely, and hopefully soon we'll be out of this and a vaccine will be available. What I would say to this is that fear is, of course, right on. Why wouldn't we be afraid? And people have a variable tolerance for that. Some people can, as the last question implied, really power that without it affecting them much, and thrive in more fear-based situations, and some people do not. In general, fear, though, like worry, is not so helpful to continue to worry about the same thing. And so I'll probably mention again later is better than worry is to make a plan and to write it down. And so if I'm worried about bringing something home to my kids, then I've sat with myself and I've written down what is my best solution here. And then every time I worry, instead of spending time in loops of worry and worry and worry, and then becoming really sometimes even incapacitated by the worry, I can turn to the plan and read the plan and say, well, I told myself that this is what I was going to look at and read when I get really worried about this. And that's about managing the fear associated with it, but it obviously implies doing what we all think is best as a response. So some people think it is best to isolate from their family during this time. Some people do not think that, which is what also makes this so complicated, is that there's no rules necessarily about what the right thing to do is. So we all have to really turn inside and use the best information that we have to make the best rules for ourselves if they're not provided for us. And some people definitely say, I'm not living with my family and working in the ICU at the same time, or working with COVID positive patients. Some people feel protected completely by PPE and change when they get home and go through a routine. So
Don Seeley from South Dakota wants to know, there's been so much negativity for the last 9 months. How do we educate people to understand what is the impact? What's the role of negative thinking on their well-being? What is the role of negative thinking on their well-being?
Yeah, brilliant questions, Dawn, out there. Thank you for that. I think negative thinking right now doesn't help us so much. Feeling our feelings does. I was talking to somebody and she said, is it the right thing for me to actually find a Frank Sinatra song and turn it on in the shower every night until I cry? I said, yeah, that's the right thing to do. Anything we can do to feel our actual feelings is right on. But anger and outrage and devaluing others and detaching, those things aren't necessarily so helpful in general for our own personal health, our own connections. And what I would say is that this is a time that we're all in our lives tested about what is it, how can we be, and how can we help other people? And I'm going to talk a little bit more about that. And my experience of that is when we focus on other people rather than ourselves, we can really go much further.
Over to you, Carla. Over to you. I think we may have lost.
I apologize. I was on mute.
Okay.
Yeah. There's a question this morning from today from Mary Lynch. Do you think the mask wearing also adds to the detachment, like a child not seeing their mother's smile?
Beautiful. Wow. Beautiful question. Yes, I do. Absolutely. So I am a therapist. Some therapists will see their clients for an hour live now still. I think it's not a great idea in terms of exposure and involves wearing a mask in the same room. Usually it's not a ventilated room, so I don't think it's a good idea. But I can't imagine actually wearing a mask and talking to somebody else who's wearing a mask and doing as good a work as I can over the virtual platform, where I can still myself really lean in and try to connect with people, and have come to really embrace being virtual and how to connect through virtual platforms. I think wearing masks is exceedingly difficult and does make me think all the way back to that still face experiment that I talked about, that we don't really know. We can't see somebody smiling. We have greater difficulty regulating with one another and interacting and touching the creativity that can cause. I don't have it in the references here, but that's Edtronic, TRONICK, the still face experiment. If you just go to YouTube, it's a 2-minute clip that is a really kind of impactful thing to see.
Thank you very much. I believe it is time to move to the second part of our presentation, Dr. Katzman.
Great. All right. So we're going to talk a little bit about what do we do and how can we be a little more resilient with what we're being asked to do and what we're all facing. And I'll talk about some general things that if you've gone in other webinars, these are some general things people talk about. There's evidence to support their efficacy, but they're important to talk about, and then I'll get a little bit more specific along here. But first, of course, is to take all recommended precautions. So we have to listen and make ourselves savvy about what is the right thing to do in terms of mask wearing and what kind of mask and all of that, and to feel comfortable ourselves. We need, many of us had an assault on the structure of our day. So people are doing 14-hour shifts sometimes, or taking care of people, and then coming home and then doing it again. So that is very difficult. It's also very difficult to be on a virtual platform sometimes 10 or 11 hours straight. And that can then, and at home when we're used to being at work. So home and work begin to bleed into one another, and we lack the separation and the structure that we've counted on. Even for many of us, getting in a car to going to work is a marker that we're missing. And so we need to think about how am I structuring my day, rather than just waking up, going on Zoom all day, taking a 5-minute lunch break, and then what else can I do to mark things, structure them. Exercise is majorly effective for many of us. Many of us had a routine. Sometimes that involved going to gyms, which are closed. And so it's so important. We all know it's so important for our physical health, for our mental health. And it's probably the one thing to really think about, if it's not an active part of our day, to get going with that in any way that we can. Be that taking a daily walk, or thinking about how we might exercise in this time. There are some dietary recommendations. People talk about the COVID-19 and gaining weight and eating between meetings and eating sometimes in stressful work environments. So we have to kind of watch that. And it's very helpful if there's a way where you live to get to nature and to get to water, that there's evidence that seeing nature and seeing water actually are helpful. Even there was one study that I saw that actually looking at a bathtub was even helpful, but water in particular seems to bring something into our brains to relax us a little bit. We're going to talk about some grounding and mindfulness and breathing exercises that can help us when our anxiety is over the top. We have to think about our relationships and what's happening with them, and we have to struggle internally about what is meaningful to us right now and how do we alter that. So next slide. It's really important right now when sometimes we're living with many people who we weren't used to living with, and we thought, and so many of us are home, and maybe there's 4 other people all on Zoom calls, all trying to live a life. And so there's for many people, a new way of needing to try to live with each other, or for people who are on the front line and come home and really have had stress that's beyond comprehension. Those transitions can be very, very difficult to family members who are not seeing that. So I said we need to honor our genuine emotions and feelings and find the people in our lives who can validate those. That's really, really important. It's probably not a good idea to watch hours and hours and hours of the news. And as I said, we want to be able to mark our day between work and home to the extent that we can. We want to, if there is something that is of meaning, some kind of project, some kind of hobby, that's really good if it's helpful, if you can find it. People have discovered passions during this time. For many people, their passions, however, have been eliminated, as they can no longer play their musical instrument, or lots of things that people cannot do. It's also important to find your space, even physically. People need a place where they can go just to recover themselves. And there can be, as people feel helpless or overwhelmed or detached, this experience of feeling passive that can be overwhelming, and it can prevent an ability to work on anything, to do anything. And we need to actually identify what that feels like and what that experience is like in order to try to move ahead and create something. Next slide. So as I talked about before, and Dr. Roy, you mentioned about this fear and people worrying, and it is frightening, the situation that a lot of us are in. And there's no doubt about that, but the worrying is helpful if it leads to the development of thinking and developing a plan. Just worrying and worrying and worrying for its own sake actually makes us less able to focus. So whatever we're worried about, if I'm worried about my parents and their isolation, I'm gonna write it down so that whenever I find myself in there, I'll take a look at it, and it says I will call them every other day to check in, or whatever that means. Or if I'm worried about bringing this home to my kids, I will turn to the list and say, here are the 8 things that I said I'm going to do in my circumstance that makes sense to me, rather than actually living with the what ifs, which are not helpful. Next slide. So a big thing to think about is how we manage acute anxiety, acutely difficult feelings, particularly for those people who are really are on the front lines working in ICU settings and having to move from patient to patient and are exhausted and are having the emergence of difficult feelings, as well as anxiety about those feelings and anxiety about what's happening. So there's a lot of evidence about various strategies that can help us to acutely reduce anxiety. Here's a list of some of those things, and I'll talk through some of them. One that's described is that you can quickly do what's called alternative nostril breathing, where you cover one nostril and you breathe in through the right. So everyone can try that. You would just cover the left nostril and take a breath through the right. And then out, and then switch. And you can do that for a little bit, and it actually just is a way to focus on the breath and can tends to calm us down. I'm going to describe another breathing exercise that comes from the psychological first aid. If anybody gets trained in that, they'll see something similar to this on the modules. So I reference them in teaching this, but this involves alternating mouth and nose breathing. So we'll just do this kind of for a minute together. So if everybody can just kind of find your feet on the floor and get comfortable where you're sitting, and take a breath through your mouth and count to 4. And then exhale through your mouth. 1, 2, 3, 4. And then inhale through your mouth. 1, 2, 3, 4. And then exhale through your nose. 1, 2, 3, 4. And inhale through your nose. 1, 2, 3, 4. And exhale through your nose. 1, 2, 3, 4. Inhale through your nose. 1, 2, 3, 4. And out through your mouth. 1, 2, 3, 4. So many people find that's a little bit of a rushed version, but you can take up a space somewhere and try one of those two, or else what's called 4-7-8 breathing, where you breathe in over a count of 4, and then you hold for a count of 7, and then you breathe out through a count of 8. And these work differently for different people, and so the question is to find a way of breathing that works best for you. Another technique coming out of psychological first aid when people are very overwhelmed in a situation is to try to do something that is grounding, so that you would name 5 things that you see, and then 5 things that you hear, and 5 things that you feel that you're in contact with. Can you go back to the last slide, actually? Last one, next one. One back one. Yeah. So it's also helpful to have access to a place that's a source, so a beautiful place where you can go to think about. That's part of a visualization and resourcing, and progressive muscle relaxation is another technique that people can use when acutely anxious, and the apps that people find helpful. One is Calm, one is Simple Habit that you can download that can actually, you do them every day to build a sense of resilience. Next slide. Next. Yeah, so we need to think about our relationships. And in Okinawa, an interesting thing. Okinawa is one of those blue zones where people live over 100. one of the longer living places. And one thing that they've discovered there is that they have something called the MOE system. And in the MOE system, people are assigned to a group when they're born, and you always belong to that group. So people never have a sense that they don't belong somewhere. And that's really important for us. We need to feel that we belong and think about who we belong to. So in terms of like our parents, if we have older parents, we want to think about how we can check in with them, how we can connect with them if they're far away, and what is good and positive right now in the family, and how can we continue in a vein of positivity rather than get dragged down into old family squabbles, which is not so helpful right now. It's very difficult to be living with children right now. And I tell patients I are working with who have kids in elementary school or preschool that to try to actually do their job and have to be an online teacher right now is one of the more difficult things that people who are at home are trying to work with and often need a lot of help through that. The stress in families is very high, right, in many families, and we anticipate that levels of domestic violence with children with significant others is higher. Interesting, it's not clear yet from my reading if that's the case, because actually since kids are not so much in school, and in many places, we don't have the same level of reporting from teachers. So that's an interesting dynamic, and it often falls to healthcare providers to start to recognize those patterns. Next slide. With significant others living in close quarters, we want to make sure we're having as much as we can collaborative discourse and saying things like yes and not but. When we're working things out and we don't want to say to our significant others, you always do this and you always do that. You want to stay with one issue at a time that you're working on and deal with what's potentially positive. And next slide. And we know that people who do best in relationships and family are flexible. This is a new study from 2020 that came out showing that the people who are doing best in their families right now and ranking their experience as with higher satisfaction right now in their relationships are open to new experiences, good and bad, are mindful of the present moments, can experience their thoughts and feelings without obsessions, maintain a broad perspective and a deeper connection with their values, and can take steps toward a goal. Next slide. So we just need to find times to connect with each other and ways to do that. The next slide. This is a nice little quote about connecting right now by the somebody authoring that still face experiment, if you want to turn back to it. And next slide. Like I said, we need to develop teams to attune to other people where trust is already there. And these programs have built highly successful peer support systems. Next slide. They use psychological first aid, which is a group of principles in teaching us how to attune to the problem at hand. That's really like a care management system. Next slide. It emphasizes safety, calmness, restoration of a person's self and their sense of connection and hope. And there's some links to the training course and to the field guide. The next slide. Those are the modules of psychological first aid. We make contact, we think about safety of a person in crisis. We do what we can to stabilize, we gather information so that we can make a referral. We offer practical assistance and connection with their social support, and then information about coping and linkage with collaborative services. So that's what people do like in a disaster, and that comes out of the disaster work of the last 20 years. The next slide. Comes out of a guy named George Everly who worked with us in Project Echo. He said something brilliant. He said he was in one of the child book that he wrote, he says, treat others as they would like to be treated. Is a revision of the golden rule, not as just as you would like to be treated, which I always thought was a nice thing about helping us all to develop our curative taking about other people and what they're going through. Next slide. And as I said, we have to think about meaning in our life and what is our connection to our future, to our work efficacy, and how we're helping the world. Next slide. There are people suffering with moral injury. I'm not going to go through all this because I think we're a little low on time here, but it is really important to be factual and transparent to the degree possible, so that people can wrestle with feelings that they have if you're a leader in an organization. Next slide. I want to talk a little bit about this though. Dr. Aurora was good to break me up into two sections here because we can't learn in more than about 25-minute chunks. That data comes out of Harvard's experience this past year actually in trying to teach undergrads who can't focus more than 25 minutes at a time. It's really important that we try to use polls and breakout rooms. In our first responder program, after a presentation, we go into what's called listening groups so that people can connect with each other. That's what people want. They beyond wanting to sign in and learn, they want to be able to meet people that they're connecting to and just bear witness and share an experience. If we can try to meet in some smaller groups so that people don't have to feel that they have to raise their hand every time they talk all through life. And it's a good thing to look around the room, to stretch, to stand up, to move around. I have trainees who get up and dance a little bit. One does cartwheels as a break actually and understands that that's an okay thing. It's good to get a blue screen for the computer that helps with the glare, and a green screen if you're gonna use virtual backgrounds, make things a little more specific so your arms and hands don't disappear. Next slide. And I've done improvisational theater for 30 years and have a book coming out actually about how the things we do in improvisation about encouraging play and spontaneity and connection really are important right now when we're all so isolated. And so there are a lot of things from the improvisational world that you can introduce into meetings. Things like giving a gift off your desk. We start some classes by just asking someone to grab something off their desk, like a bottle of water, and giving it to somebody else in the room, and why. We tell stories one word at a time. We learn about each other in different ways. And it's really important to be able to connect, as I'm saying, because isolation and loneliness were a scary epidemic before this ever started. Next slide. And in the end, you know, we're all a little more real for this. It makes me think about the Velveteen Rabbit a little bit, and the Skin Horse and the Velveteen Rabbit asking about what is real. And the Skin Horse says it doesn't happen all at once. You become, and it takes a long time. That's why it doesn't happen often to people who break easily or have sharp edges or have to be carefully kept. Generally, by the time you're real, most of your hair has been loved off and your eyes drop out and you get loose in your joints and very shabby. But these things don't matter at all, because once you're real, you can't be ugly except to people who don't understand. Once you're real, you can't be unreal again. It lasts forever. I think that's a little what's happening to us all, as we're becoming a little more real through this shared experience. So that's what I got.
Thank you. Thank you. And Carla, I wanted to make just one announcement before I turn it over to you for questions. And this is that some of the questions that came were regarding the pandemic and how to deal with it, other than psychological safety and other types of issues. So I want to just tell you that on December 7th, we have a global conversation series which says Science and the Response to the COVID-19 Infodemic. And this will cover all the science that we have. This session will be led by Dr. Soumya Swaminathan, the Chief Scientist of the World Health Organization. And we'll have experts from around the world talking about the science that is coming out from all corners. Second, on Thursday, December 10th, again, we have another global conversation series specifically on 2 new treatments that have been recently approved by the Food and Drug Administration, the antibodies. One is a monoclonal single antibody by Eli Lilly and Company, and another is a combination of 2 antibodies by Regeneron Pharmaceuticals. And these are currently in your hospitals now, treatment for early stage COVID-19, how to use them, etc. What's the data? That's December 10th. December 14th is another one. And you can see we're doing it more much more commonly right now because the science is advancing quickly. Global success in managing the COVID-19 pandemic, which we'll talk about the rest of the world, what they're doing. And December 17th will be a full session on vaccine development and distribution. As you may have heard, that the vaccine will be available in the United States by December 13th. In fact, it is expected that 6.4 million doses of the vaccine will hit our hospitals around December 10th, 11th. And so on the 17th, we'll have this session. So just wanted to let you know that this is all coming, and you can mark your calendars if you have an interest in other aspects of this pandemic. Over to you, Carla.
Thank you, Sanjeev. Thank you, Dr. Katzman, for that really lots of good information on how to try to take care of yourself and your staff. There are a couple of questions about when you have staff that are quarantined at home in isolation, how to keep in contact with them, if you have any specific advice about how really to help those people get through quarantine.
Yeah, just make contact. I think checking in virtually, giving people roles and things to do is all really helpful. I mean, I think particularly for people who are wired to help and find themselves unable to do so, it's very, very frustrating. So trying to figure out a way that people can stay engaged is really, really important. I think it's a thoughtful question, because I think often when people are in quarantine, they might just kind of fall off the radar for people. So I think even the idea that someone's thinking about, well, how do we help somebody who is in quarantine is really, really helpful. I've heard many, from my vantage point, of the college kids who wind up in quarantine, which is really difficult to hear about, during freshman years of college, being quarantined in a dorm alone by yourself for 14 days, unable to leave the room, so people are going through very difficult situations, and it's being thoughtful, like whoever wrote that question, is a really is where to start.
Thank you very much. There's a question from Guali Sosa Pascual. Are you aware of specific technologies and interventions that are being used in innovative ways to reduce isolation in long-term care facilities among families, caretakers, and residents?
We've struggled with this. We've really struggled with actually getting virtual access into long-term care facilities ourselves. So I don't feel like an expert in this, but I wish whoever wrote that question could inform me a little bit, because this is a really a huge problem, both in terms of people's ability to use the technologies, the availability of the technologies that we all take for granted. We have a geropsychiatry clinic and have had a lot of difficulty setting up those virtual appointments through Zoom for people who are living in residential facilities. I think that families, many have figured out how to FaceTime and use various internet-based technologies that are easy to make contact in scheduled ways. I think that's the most important thing and highly meaningful for people, but it does involve at least a technology like that, like FaceTime. More difficult to set up a lot of times the medical appointments. If anybody has a great answer to that, though, maybe they could put it in the chat. I don't know if that's possible.
Thank you. Back to you, Sanjeev.
Thank you, Carla. There's a question from Anjana Bhushan from India. She asks, what are the gender, equity, human rights dimensions of this pandemic in health and non-health aspects? I think that a lot of people are feeling this stress that, this pandemic is really worsening the tremendous disparities that previously existed. For example, in the United States, the death rate for African Americans can be 2 to 3 times greater. How does one deal with that larger global? So it's not fear and anxiety personally, but it's this issue of are we being good global citizens and dealing with the issues that are affecting all of humanity?
Right on. I mean, I think that's correct, and I think that's actively enhanced a discourse, and I think the importance of curiosity and perspective taking and being able to actually understand the perspective of another person from another background is becoming ever so critical. While we see people of different backgrounds suffering to greater degrees with fewer resources, less access, fewer educational resources, and access to information is, I think, one of the biggest things that we can think about right now. I think there is, in some pockets of the world, a dawning of consciousness around it, but it's, I think, one of the most important things we can think about. On a really micro level about this, really micro, with what I deal with, I talk to two working parents raising kids, both with full careers, quite a bit. And somebody's got to give up their career to stay home and raise kids and be with them. And I think that there are gender things that happen with that, that I observe that are also very difficult in terms of who stays home and how that works. I just think it's all around us in terms of healthcare disparities and access to information, our changing roles, the changing our responsibilities. Do you have anything to add to that, Dr. Arora? You're an expert really in this area too. I mean, you've, beyond more than anyone I know, have tried to address this this question.
Yeah, I think that there is a huge difficulty in the world, specifically gender equity. Women are not able to travel as much. They are not able to access healthcare as much. In many parts of the world, they tend to have a lower social status. So when limited resources are available, they don't come first in line. And I think we need to be totally aware of the fact. For example, right now, the antibody is going to be available in the United States. And Lara, this is not related to your talk, but Lara Barkov has asked this question: how should I get my patients this antibody? So in the United States now, the antibody is actually available in the hospitals. So what Lara should do is she should call her local hospital, and they are setting up infusion centers, but it's not available anywhere else in the world. Similarly, the vaccine, we are going to have the vaccine in the United States. It appears that the head of the Operation Warp Speed has recently said, as recently as just a day or two ago, that by the end of May, 70% of the people in the US should have received the vaccine. That is the pace at which it will be rolled out. And they've done tabletop exercises, etc. But of course, the next question then comes is, what about the rest of the world where we are taking the vaccine and keeping it all for us? And of course, here we are going to prioritize healthcare providers, but what about all the other healthcare providers in the world? So I think this raises a lot of issues which we need to grapple with as a society, because this kind of inequity that exists all over the world is not compatible with peace and harmony amongst the nations, and maybe at the root cause of a lot of terrorism and a lot of wars. And so I think it requires a much more global conversation on how to deal with all of this. But thank you. And
the other interesting thing to that, Sanjeev, is that the pandemic doesn't go away if it doesn't get all over the world. So in that way, we are all in this together, and it is forcing us to really realize how are we going to actually help people who have been out of access to care and those kinds of things, because now everybody is actually interconnected in this way.
Thank you. Carla, go ahead.
Thank you, Sanjeev. There's a sort of related question that came in through the question and answer. It says, from Mark Clark, with so much focus on disproportionate burden of COVID on communities of color, are there unique cultural or mental health tools that you know of that could help families?
I wish I could understand a little bit more about the specificity of that question.
Yeah, I think it's just that culturally specific tools or things that could be used by people from different and unique cultures, I think is the question.
Mm-hmm. I think what I know about that is just hearing from people in our listening groups on the first responders call about how people from different cultures are actually connecting with one another and taking strides to do that, and would be difficult for me to kind of encapsulate kind of all cultures in one response, but I think the idea of actually understanding what it means across culture to reach out to somebody is really, really important.
Yeah. Thank you very much. And there's a question from Harry Seibold, who frequently comes to these echoes and asks great questions. He's asking about having to deliver bad news over the phone or virtually, and how, as you know, a lot of the stress for healthcare workers now is having to deliver this source of bad news not in person. And if you have any advice about anything to assist with that.
Yeah, is horrible. And I think that's just what we can do, is actually to be as transparent as possible and as compassionate as possible, and take time. And I think the biggest problem comes when we avoid the conversations or avoid taking time to talk with families. And I think if there are ways to virtually set up meetings with families to actually share information and to process that information and to work closely with palliative care teams and the clergy, who are taking on really in our hospital like the brunt of this, and really, really beautifully impressive way of actually, even in their rounds, honoring the spirit of people who have passed on and talking about who they were to each other. In witnessing the rounds of our palliative care team led by the clergy, I was really blown away by that experience. So I think there is the issue of expressing difficult news and not avoiding it, but then there's also the issue of connecting people to services and staying in there, and what can we do to support families who are really struggling with this, often particularly in our state, in New Mexico, where sometimes in the Native populations we've seen both parents die, multiple people within a family pass away. Very, very difficult situations.
Thank you. And someone just put into the chat, Lynn Wilson, that hospice organizations can be super helpful for things like that, trying to deal with difficult conversations. Yeah, there's a great, Elaine Struthers put in that she says in her town that in my town, I see groups of families sitting outside ICU rooms on the lawn outside hospitals, sometimes for days. And I'm trying to think of possible pop-up support strategies, even so simple as an organization bringing coffee. Have you seen anything like this?
Say that one more time. I got distracted by the chat.
She sees people's families sitting outside of hospitals on lawns, basically because they can't enter. Have you seen anything? She's asking about pop-up strategies, like delivering coffee, things like that. Have you seen anything like this in your own community?
Yes, and actually we've saw it a lot from medical students actually who were not able to themselves be on the units, actually becoming kind of supportive of teams in exactly that way, or helping actually patients connect online, and serving various support activities.
Thank you. Back to you, Sanjeev.
Yeah, one question perhaps you could help us with is, because of so much concern of helping their colleagues at work, is what signs and symptoms should a healthcare worker be looking at to identify signs of stress in a coworker, so that they can do some of the things that you talked about, the empathetic listening, perhaps guiding them to come and listen to this talk, because it'll be on our website. If you have, if any of you who are listening today have people who would benefit from this talk, please have them come to our website. This is, as I'm reflecting on all our global conversation talks, I'm thinking this is one of the most helpful ones. for our global audience. So I hope they can come and actually hear Dr. Katzman themselves sort of get some of these tips and ideas. But just for this question, if you could just tell us what should they be looking at, and then what should they do next?
So I think we are complicated human beings. And so we all respond differently to situations. And so really the thing I look at and I wonder about is just change, that somebody's and that somebody's seeming overwhelmed by situations. And that usually, in my world, it often looks like either anxiety that's unmanageable and people are more tearful as a result of trying to diffuse that anxiety, or more shaky, or talking much more rapidly, or having difficulty focusing. So that would be one set of kind of anxiety-driven symptoms. And then those symptoms of detachment, where people just can't care anymore, and don't interact so much, and don't show up maybe to things, and don't have the same humor that they once had, seem to be disappearing. So that would be the other set of things I would wonder about.
Mm-hmm.
You know, I was also aware of the time. I also just want to throw in here, because there have been questions from managers about what to do to support teams. And I think a lot of us now are thinking about, holidays, we're kind of at holiday time, and people can't get together with their families, and they can't get together. Like, how do we show appreciation for people in these times, where somebody might have had a holiday party for their staff or something like that, and now cannot. And I think it's important to really put consciousness into what that might look like, and what people can do right now, just show gratitude and appreciation. And there are interesting websites that one can find where you can have, at least in the US, various activities. And I have ideas about those, but one of those is just to have a series of maybe a virtual meeting, and a series of questions that people can talk about in breakout rooms, like what's their favorite holiday memory or something, and get to know each other in groups of 5 or 6 in breakout rooms, and think about something other than work, and realize that we are in the workplace, part of a family, and really these are some of our most important relationships, and we need to honor them like we usually do. So it's another kind of we don't do something right now, it feels like yet another thing that's happened in 2020. We didn't get together, I thought, in any holiday way to just kind of have any kind of mark of celebration together. Same thing when people leave the workplace. If there's a way to actually get together, the group, to virtually have a talk about the person who's leaving, and to honor the person who's leaving. These things that we might have done at work in the real way, we need to be able to try to do virtually, and think about how we do them.
Over to you, Dr. Thornton.
Thank you, Dr. Katzman. I'm going to go back to there was an early question that wasn't answered about PTSD, and relating to what you said in your first part of your talk. It says PTSD is real but imprecise diagnosis, and with very, very varying symptoms, can occur in a very few staff and cases and paramedics. There's a tendency to dilute meaning and to denote any significant trauma response as PTSD. How can you better define people who truly have PTSD, and so that you can help people with the specific intervention that would be useful for them?
Great question. Really, really great question. I know I used to work for at the VA for 10 years, directing behavioral health services and running the programs for Vietnam veterans with PTSD. And the term can get thrown around like water, really, and lack the specificity and dilute, like the questioner is saying here, the sense of meaning. That's very important. So I think we can think in ourselves and in our coworkers if people are experiencing those symptoms, and talk to them about what's happening for them, and talk to them about potential referrals. There sure are a lot of evidence-based treatments for the treatment of PTSD, cognitive processing of traumatic experiences, and exposure therapies, and they all have various efficacies. For me, though, personally, and the EMDR, and these are all various trauma treatments. For me, the most important thing is that somebody's not left alone experiencing these traumatic memories, and is able to actually talk about them in whatever format that is, with somebody that they can trust, and ultimately face their feelings about the traumatic event. Because, like the questioner implied, these things are highly personal. The stories and the images and the sounds and the smells, they're all highly personal. And those are what get locked up inside of us to be able to share with somebody, so that we're not all alone with it. I learned that firsthand in a car accident in which my car rolled over twice when we were hit by a 15-year-old, and I had my 3 kids in the back seat. It was a very, very difficult situation. And then I started to actually, while driving briefly, see cars coming from the side that looked like they were going to hit me. That lasted just very temporarily, but it was very helpful to actually go step by step into what I remembered about with somebody who was skilled at working with that. And you know, I'm sharing that because that's a highly personal story, and these experiences are all highly personal with patients that we've treated, who we've known, and things haven't gone as we hoped.
Thank you for sharing that. Warren Heffron asks, can we use people's spiritual beliefs to help them cope?
Absolutely, yes, absolutely. We on our first responder program have people who are well versed in various spiritualities to help us, and I think it is very helpful if somebody has a spiritual practice to be able to turn to that and to feel supported by that. It eases, it facilitates a sense of connection, and connection to something bigger and something greater, and that is extremely helpful. Mm-hmm.
Thank you very much. I also just wanted to say, I apologize. There are so many questions that came in beforehand, and a lot have come in during the presentation, and we apologize if we aren't able to get to your question. I wanted to give it back to you, Sanjeev.
Well, thank you, Dr. Katzman, for sharing your time and expertise. There are many questions here about the pandemic, and especially Joanne Bennett wants to know from Ghana what are available in different countries. Also, others from Africa want to know about the treatment. So maybe I'll make just a couple of comments about that and then wrap it up. I think that we're happy to also have an expert in the area, Dr. Carla Thornton's infectious disease doctor. And so there are 5 essential treatments available all over the world, right? There's dexamethasone, which is available in all the countries and has been shown in randomized controlled trials to be effective in moderate to advanced disease. So that, I think, is definitely there. I think there is this issue of fresh frozen plasma or human plasma of people who have recovered, that there is trials have not shown effectiveness, but is being widely used in low and middle income countries, and often sometimes in the United States still without really. There is this issue of 2 antibodies that have come out, which are mostly available only in the United States right now. And so not very relevant for different parts of the world, but should become available in a month or 2 elsewhere, but they will be expensive. And so I'm not exactly sure. These are going to be effective in the very early stages of disease, and high-risk patients may actually harm patients in later stages of disease. And then there's remdesivir, where there are contrary opinions. WHO is not convinced about the benefit of it. On the other hand, the United States FDA has approved it, and perhaps will be beneficial in early stages of the disease. It is available in some low and middle income countries, not in all. But essentially at this point, the dexamethasone is the only real treatment, and plasma, and as I said, plasma is not really proven yet. Carla, did you want to make a comment or so about this issue, just so that people, since so many questions came in before I wrap it up?
About plasma, about antibodies in particular, Sanjeev?
Yeah, about not about the US antibodies, but about the plasma, because
Yeah.
that's what's available in
Right.
Ghana and in other low-income countries. For Ratu, Zakari also asked the same question. Yeah.
Yeah, certainly. Sanjeev said in the US, the trials that we've looked at have not been that successful, and it really isn't being recommended here in this country. One of the problems was that people make very different levels of antibody, and it may be that it would be very effective if you got somebody's plasma who had a very high level of antibody in it, but unfortunately it's just not consistent. And so at least we did some studies here at our own institution, and it looked like it was very important to be able to measure the level of antibody, and so it's just not you can't predict how someone will react to not knowing the level of antibody in the plasma.
Thank you. Well, thank you all who've attended this session. We're really, really delighted to be able to interact with you. And the CME, Continuing Medical Education, and CEU links are available and will be included in the follow-up email. It is really important that you give us feedback on this session, how we did, how we can improve it. And resources that were linked in the chat will also be available on our website if you want to go in. And please watch for our email for session updates. And thank you again for working with us on the Global Conversation series. Bye-bye. Over to you, Tabitha, team. Thank you. See you on December 7th. Bye-bye.
Bye-bye.